from the American Academy of Pediatrics.
Everyone's favorite book about pediatric nutrition has a new update.
The 9th edition of the AAP's Yellow Book offers research and guidance for all age groups.
Pediatric nutrition is hard. We want to make sure that parents know how to feed themselves preconception through adulthood and also to optimally feed their kids.
But first, it's May, and that means it's time for a new First Up.
These early interventions are really the ones that are most likely to have a sustained long-term effect. So I'm very excited to see what happens next and to see how people build on these kinds of interventions.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Balinki.
And I'm Dr. David Hill. This podcast is for everyone in the medical community keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode by looking at the latest research in the journal Pediatrics.
David, has this podcast ever directly changed how you practice medicine?
Oh my gosh, too often to count. Perhaps the greatest change, though, was in implementing the updated newborn jaundice guidelines at both hospitals that I staff. Alex Kemper helped us get that right and fielded way too many phone calls and emails in the process.
When we went over the role that fathers play in breastfeeding and safe sleep, that got me. So now when I go into family rooms, when I'm rounding in the nursery, I always talk directly to fathers to ask them how they're supporting their partner in a breastfeeding journey. And it's just really influenced me in a big way.
I have to wonder what our listeners would say when they think about the episodes that they've heard.
I'll tell you this, David, I've had so many people tell me how much First Up gets them excited to listen because we do a rapid fire of pediatric articles and they know what to focus on to read. It's definitely a fan favorite. And today we have the editor you just mentioned, Dr. Alex Kemper.
Hello, Joanna. Hello, David.
Hi.
It's
Hey,
so great
Alex.
to be here, and thank you for the support and the opportunity to do the First Up. It's a real pleasure with us to be able to share the exciting new findings that are coming out in pediatrics.
Well, we are excited to have you with us again. And Alex, I'm almost afraid to ask, but has the podcast ever taught you anything? Or is this all just a brain dump for you in your role as deputy editor at Pediatrics?
Oh, it's totally not just a brain dump. I listen to the podcast all the time and I learn things constantly. But I have to say, since you brought up the issue of the bilirubin guidelines, maybe we can just talk about that for the next 2 hours.
I got time. Let's go.
I'm glad, Alex, that you are not bored of speaking of that yet.
Not at all. Not at all.
Well, since we were talking about pediatricians, why don't we start with an article about them? Not what they have learned from us, but how they are learning in training. So much has changed in residencies around the country. Are measures like a required curriculum and work hour restrictions creating a more informed pediatric workforce?
You know, medical education and how we prepare our residents for practice has just changed so radically since when I was a resident. I think one of the biggest changes is the move to competency-based medical education. So the idea there is it's not just about learning facts and figures, but are we training people to be able to go out into practice and provide care? And one of the key aspects of competency-based medical education is entrustable professional activities, sometimes called EPAs. Although I've heard other people refer to them, and I think it's easier to understand what they are, thinking them as everyday pediatric activities, things that pediatricians should be able to do. So there are 17 EPAs, entrustable professional activities, that residents are expected to be able to do for primary care. And this month, we're releasing a study called Graduate Residents Readiness for Unsupervised Practice. The lead author is Daniel Schumacher, who's at Cincinnati Children's Hospital, but it really has an all-star cast of educators who are on it, and they represent the Association of Pediatric Program Directors Longitudinal Education Assessment Research Network, or APPD Learn. And what they did was they looked over 3 different academic years. So the 2021, 2022 year, 2022, 2023, and 2023, 2024 academic years. And they looked at how clinical competency committees assessed graduating pediatric residents' readiness for practice according to these 17 EPAs. They looked at nearly 2,300 graduating pediatric residents overall and nearly 200 graduating MedPeds residents. And what did they learn? So they looked at how the graduating residents were doing across these 17 EPAs for primary care, and they found that according to the clinical competency committees, only about a third of them were deemed ready for all of the EPAs. So the ones that residents across the board were more ready for were things like health screening, well newborn care, providing medical home services for well children, and being able to refer to consultants. And the ones that were lower were related to practice management and resuscitation and being able to recognize and refer for surgical programs. These are things that residents in general oftentimes get less exposure to. So perhaps it's not totally surprising that they didn't meet those EPAs. But the question is, what does that mean for pediatricians going out into practice from residency? Is this something that we need to worry about? Well, we got a commentary from Dr. Hilary Haftel, who's in the Department of Education Science at the American Academy of Pediatrics. And first of all, she points out how revolutionary competency-based medical education is, and she really praises this as a new paradigm and stresses that we're still figuring out how to best both assess the EPAs and develop strategies to help residents meet these criteria. And she also points out that the new residency requirements that are just about to come out offer more flexibility in terms of training residents. There's more opportunity for them to pick rotations to fill in knowledge gaps. And also the new pediatric residency requirements are going to give pediatricians more time in the ambulatory setting, which overall is likely to help boost up where the issues are with these EPAs.
Well, I am just so grateful that I got through my medical training and out into practice that I am taking a deep breath. Speaking of breathing, let's talk about pneumonia. How's that for a transition, Alex?
I was holding my breath to see how you were going to get there.
Thank you for that. So speaking of pneumonia, as we were, chest x-rays can be a helpful diagnostic tool for pneumonia, but when do we order them? And if they're normal, is that the final word?
That's a great question. So we're publishing a study this month, Risk of Subsequent Pneumonia After a Negative Chest X-ray in the Emergency Department. The lead author is Alexander Hirsch, and it's written with other colleagues at Boston Children's Hospital. And they asked the question, if you have a negative chest X-ray in the emergency department, do you need to worry that maybe a pneumonia will develop later? So they looked at children less than 21 years of age who had a negative chest X-ray within the emergency department. They looked in a single emergency department, but actually over a 10-year span, and they ended up with nearly 10,000 subjects with suspected pneumonia and a normal chest X-ray in the emergency department. And they looked at who had a follow-up chest X-ray within 14 days and whether or not that X-ray was positive for pneumonia. And the good news is that of those 10,000, there were only 240 that had a follow-up chest X-ray within 14 days. And overall, there were only 27 who had signs of pneumonia on the X-ray within that 14-day period. I thought that was interesting that about 8 of them actually had a positive chest X-ray within 8 days. And the other thing that's reassuring is that clinical signs that were apparent at the first X-ray can be predictive of who's going to develop a pneumonia later on. So things like dehydration and tachypnea, low pulse ox, so things that would make you more concerned and more likely to follow that patient. So the good news and the thing that's really reassuring is that the likelihood of having a pneumonia develop after a negative chest X-ray is really quite low. And use your clinical common sense to think about those children that you need to follow closely.
That's great advice for me in the NICU as well. And as a neonatologist, I'm always really fascinated by how you can trace chronic diseases to fetal life. Obesity is a chronic disease we know has roots in early childhood, but how much can we influence the development before birth? Can we treat it starting in pregnancy?
That is a great question. And as you know, there's a lot of interest in what's referred to as the first 1,000 days, including the period during pregnancy, as a time that really is associated with chronic disease down the line. And that if you can maximize fetal and early childhood health, you can really make an impact during the long run. So this month, we're publishing a study by Christina Kim and colleagues from the NYU Grossman School of Medicine entitled Child Obesity Prevention from Pregnancy, Long-Term Follow-Up of the Starting Early Program trial. Now, the Starting Early program is a really interesting and innovative intervention. It's something that begins in the third trimester, and between the third trimester and 33 months of age, the program has 15 different nutrition and parenting support sessions. And the sessions that happen after the baby is born, after 1 month of age, are actually group sessions, which are, I think, just really great for getting families to interact and learn from one another. So the study that we're talking about today with the Starting Early program focused on Latina and Hispanic women. It was a randomized trial, and what they found and have reported earlier is that the intervention led to improvements in diet, activity, and weight trajectories through the first 2 years of life, although the weight impact didn't extend to 33 months. What we're publishing now is a study that looks at when the children are 4 or 5 years of age, so adding another couple of years into the follow-up period. And what they found out, looking specifically at obesity, that overall across the population, there was no overall differences. But when you drill into things, the subgroup that had higher attendance, so if you were to attend 11 to 15 of the sessions versus fewer than 11 sessions, that did have an effect on obesity prevalence. So we're talking about 9% if you attended most of the group sessions versus about 27% if you didn't. And there's a lot of reason to expect that this would have a long-term effect because of the issues we were talking about before, Joanna, with early childhood programming. Now, we did invite a commentary on this one as well by Dr. Richard Bowles and Huma Anelli from Children's Hospital of Colorado. And they underscore the importance of this intervention for starting in the prenatal period. And they're very excited about interventions around the first 1,000 days. Now, they point out some limitations of the study. And of course, any long-term follow-up study for a randomized trial has issues with loss to follow-up, for example. But they point out that these early interventions are really the ones that are most likely to have a sustained long-term effect. So I'm very excited to see what happens next and to see how people build on these kinds of interventions.
Well, Alex, talking to you has had a sustained long-term effect on my pediatric knowledge base.
Would that be a positive one?
A positive.
Okay, good.
Sustained.
I just want to clarify.
I am rich with knowledge, even more so today, stuff I could take back to my hospital and use. So do you have any last words of wisdom for our listeners before we let you get back to all your other work?
I would say these are challenging days, and I think it's important to take advantage of self-care as you can while you're also providing excellent clinical care.
Well, and what do you do for self-care, Alex?
I go on this podcast.
So everybody needs to come on.
Correct. There's going to be a long, long, long line.
What our listeners cannot see is that Alex is joining us from a bubble bath right now.
Exactly, and drinking my champagne.
Yeah. I mean, you look good. I'm a little jealous.
Dr. Alex Kemper, thank you so much for joining us today.
Thank you.
To read these articles and more, visit our website at aap.org/podcast.
Coming up, we'll discuss the latest updates to the AAP's Yellow Book, Pediatric Nutrition. Joanna, I know you were worried about baby Zelda's weight there for a while. How are things going for you guys now?
Well, she had a tongue-tied diagnosis pretty late and wasn't the best at sucking, but then she started solids and things really picked up for her. She loves so many foods and we haven't had any allergy scares, so she's trucking along on her chosen percentile.
Ah, man, in our world of pediatrics, weight, length, and head circumference are critical vital signs, so I can see why you were worried. And of course, you can't have growth without nutrition. So as pediatricians, we spend a lot of time thinking and talking about nutrition.
Well, David, you know I'm a neonatologist, so in the NICU, we are thinking about TPN, different formulas, feeding protocols. But David, you have to counsel older kids on their diet and on beverages, which is a little bit more complicated, especially for someone like me. Where do you turn to when you run into questions?
I always start at what we in the AAP call the Yellow Book, but its real title is Pediatric Nutrition. It's like the Red Book, but instead of the AAP Committee on Infectious Diseases, it's authored by the AAP Committee on Nutrition. There's a new 9th edition out, and the ebook is free for all AAP members.
Oh, I've already redeemed mine. But even better than that, today we get to talk with Dr. Ellen Rome, a contributor and former member of the Committee on Nutrition. Dr. Rome serves as head of the Center for Adolescent Medicine at Cleveland Clinic Children's Hospital and is a professor of pediatrics at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve. Ellen, welcome to the show.
Thank you so much for having me.
I want to start by throwing something out there for you to respond to. I hear so often doctors don't learn anything about nutrition in their training. Do you think we give nutrition the attention it deserves in pediatrics?
Well, nutrition is essential from preconception all the way through your geriatric years, and it's a harbinger of good health and wellness as well. And we can prevent illness, we can proactively promote bone deposition and brain development and all these great things. So should we be teaching it better? Absolutely. And from when I was in med school, I think we got an hour on it. Nowadays, there's a little bit more because people are having more interactive and better curriculums that focus on prevention as well as consequences of disease. But things are more skewed towards everything around obesity and a little less around eating disorders, even though it's not a spectrum. You can be obese and have an eating disorder. You can be overweight and still be well physiologically. And we want to teach more of that so that we can get it back to patient-centric counseling around nutrition across the life spectrum.
Speaking of the life spectrum, I mentioned I'm a neonatologist, and I know there's a lot in this book for me and my colleagues. Can you talk about what's in there for newborns and preterm infants?
Thank you for asking. There's an awesome chapter on the nutritional needs of the preterm infant because we know that nutrition is key from preconception all the way through the geriatric years. And we want to be doing it best from before they come out all the way through those critical days in the NICU or in the newborn nursery through that transition home and on. What we've found is that human milk from the infant's own mother is the ideal enteral feeding for a preterm infant. And it contains living cells, including stem cells and many other bioactive factors that contribute positively to an infant's well-being. Human milk is generally well tolerated by preemies and promotes early achievement of full enteral feeding compared with infant formula. And we know that infants in that preterm, especially those first 3 days, in order to be in positive energy balance, especially nitrogen balance, need a higher amount of protein than we'll need later. So that's kind of a critical piece. And we've got tools in this chapter to help you with growth from birth through those first 40 to 50 weeks of life, because parents and pediatricians are worried about catch-up and making sure that they do well, especially when they come out as our teeniest, tiniest tots and very low birth weight infants, etc. After discharge, nutrition's still a key thing. So relatively healthy is kind of a wide variability, and we want pediatricians to partner with NICU follow-up folks and parents to make sure that we're helping with this catch-up growth and with optimal brain and body development.
That is fantastic. And as somebody who works primarily as a newbornist, I really appreciate that. You mentioned earlier that there is a lot of focus on obesity. We did talk with Dr. Sarah Armstrong on episode 144 about the updated AAP obesity guidelines. With so much focus on obesity and overweight, can you review what has changed in this new edition of the Yellow Book?
So pediatric obesity has shown a dramatic increase over the last 4 decades, and it's the most prevalent chronic condition among U.S. youth today. The prevalence right now in 2 to 19-year-old U.S. kids went from 5% in 1980 to 18.5% by 2015, 2016, and we're not much better in 2025. So this is a global problem and has healthcare costs and has become a public health priority. What's new here is that we really want to be child-centric in our language. We want to be careful not to weight shame anyone or create stigma. And we want the messaging to be healthy and well-being and not the Charlie Brown teacher voice, wah, 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 like the things that you don't want to do, which is body shaming, weight shaming, etc. So we expect to see pieces in the chapter on lifestyle management and dietary modification and physical activity and the basics of sleep. We also want to make sure that pediatricians and parents and communities are body positive and can help partner on solutions. In fact, the CBG presents a plethora of data on the how-to on obesity management, and yet we were finding that there are many, many kids with disordered eating who are overweight and obese. So we have a whole new, and this is a teaser for the future, position statement that will come out in the next, 18 months, hopefully faster, that deals with how do you coach up parents, pediatrician partners, other folks on how to address that cadre of folks.
You know, another topic this book addresses is the COVID pandemic, and I never thought about the effects of the pandemic on nutrition. So can you help me understand what they are?
The pandemic isolated a ton of kids. Many of them dove into the internet. And so we had a sweeping increase in eating disorders and obesity. And again, remember, those are not an either or. You can be an obese and have an eating disorder. You can be skinny and have an eating disorder. You can be overweight and be well. These are not either or situations. What we found is that kids often were in situations of food insecurity because they weren't getting meals at school or regularly. And so we had kids in front of computers, boredom eating with an increase in binge eating disorder. We had kids who were under eating or lacked food access, or dove into the internet and found social media where it was the super peer encouraging that disordered eating or fad dieting behavior. So in the first 2 years of the pandemic, an additional 5% of kids in lower income populations experienced new onset obesity with worsening disparities. But if you looked at race, ethnicity, income, outpacing the increase in prevalence during the prior 2 decades combined. So the pandemic didn't do kids any favors or families. We also found that the pandemic had many kids isolated with more mental health challenges. And when you are depressed or anxious, you can overeat, you can undereat. There's all sorts of maladaptive coping behaviors that go hand in hand with mood disorders as well.
So there's a lot of talk about ultra-processed foods right now, and I know the Yellow Book does not currently address that, but there's also a ton of buzz about genetically modified organisms and organic foods. And what does the Yellow Book have to say about that now?
Well, we know there's an explosion in consumption of organic foods in the U.S., with basically a doubling from 25.1 billion to 56.5 billion from 2011 to 2020. And we know that bioengineered foods is big business. And there's a lot of food myths out there that parents are trying to digest, so to speak. So For instance, if you follow USDA labeling, organic labeling guarantees non-GMO status, but non-GMO labeling does not necessarily mean that the food is also organic. So this is confusing to parents and pediatricians often. And we want to encourage organic foods, but we also don't want to bankrupt families. So we want to make sure that we go for progress, not perfection, in feeding our kids. And where organic can be economically chosen, we're all for it. When it's impractical, aiming for more whole grains and fruits and veggies and et cetera that are non-genetically modified foods, non-GMO, is a great starting place. And where you can do both, that's awesome.
I mean, are GMOs bad for you or bad for kids as they develop?
Putting this in layperson's terms, GMOs means genetically modified organisms that can tolerate higher pesticides so that the plant can still flourish. So when you're doing non-GMO, you're getting less risk of pesticide exposure. Organic foods reduce pesticide exposure as well. So we're trying to avoid cumulative pesticide exposure in all of us, but especially in kids. There's other practical pearls for parents. When you eat fruits and vegetables, wash them and scrub them well and remove the outer layer by peeling or taking off the lettuce leaves or the cabbage leaves or the outer skin of the carrot, because that's where the pesticides are. So simple washing will help. Choosing organic instead of non-organic when it's affordable. And when you're thinking about organic farming, organic means no use of antibiotics for the farm animals that are making the milk or providing the beef or the chickens, et cetera, providing the eggs. So organic means no antibiotics. Our family recently went to Costa Rica and we were driving across the countryside and saw all of these skinny cows. And so we asked one of our tour guides about that. And he said, well, that's because none of our cows use hormones. They're not all fattened up like they are in your country. So there's some truth to what we see and how we live and what our choices are. Now, again, bottom line is families have to be practical and make sure what they are choosing is affordable. So where you can, non-GMO, and where you can, organic, are great choices. And do your best and don't have perfection be the enemy of progress.
Well, Dr. Rome, you are an adolescent medicine specialist, so I think we'd really be missing out if we did not ask you if there are any special considerations in this update for our teenage patients.
Of course there are. So we have a whole little bit on sports nutrition. For instance, there's a newer, not so new, but newer diagnosis called REDS, Relative Energy Deficiency Syndrome in sport, where they may be overdoing what is healthy eating in the pursuit of increased athleticism. And this may be driven by the kid, it may be driven by the parent, it may be driven by both. And the challenge is helping them realize that they're underfueling themselves for what their energy needs are. So I tell kids it's more like you're fueling yourself like a toy car instead of like a Ferrari. And so if your energy intake is far less than your energy expenditure, you're running on fumes, literally. So we need to help kids and families figure out how to eat better. So there's strategic fueling that you can do to improve your sports performance. Besides getting adequate protein, fat, carbs, energy intake, et cetera, micronutrients, we also in the Yellow Book note that how you eat after, for instance, a 60 or 90-minute workout matters. Like you want carb within 20 minutes of stopping so that you can build glycogen stores for endurance. Telling kids the why matters and can help them change to more positive behaviors. We want to make sure that they're getting adequate hydration before, during, and after exercise. So making sure that they know to drink enough that their pee is clear instead of bright yellow. We want athletes to drink 6 to 10 glasses of fluids a day. And if you work out for an hour, okay, that's 2 extra cups. So helping them with the pragmatic pearls to make it understandable is important.
So I also want to take advantage of having you here because we have two young adult daughters who are both vegetarian, and sometimes it's hard for us to figure out what we're going to feed them. Does the Yellow Book address the needs of young vegetarians?
Yes, David, it does. And thank you for mentioning that, because it's super important. Vegetarian and vegan meal plans are not necessarily unhealthy. We worry about it when it's a new vegetarian, especially in an omnivorous or carnivorous household where the parent has no idea what vegetarian is and lets the tween or teen follow their path basically unmonitored and potentially cluelessly. So vegetarian and vegan meal plans can get you all the nutrients you need. And vegetarian meal plans can be ethically an imperative for some kids or families. And it may be a way to decrease cancer risk or other gut changes. And it can be a form of intentional and healthy weight loss, or it can be a red flag for an emerging eating disorder. So if somebody's new vegetarian, we're going to want to make sure that they know how to do it in a healthy way and well. If somebody has a vegetarian household because of religious or cultural preferences, it's fair game to partner with a pediatrician to make sure that you're getting that kid and that mom breastfeeding or when the kid's in utero or otherwise taking care of themselves adequately to meet their and their kids' nutritional needs. So vegetarian can be a super healthy way to eat as long as it's not used as a means of restricting intake.
And I love that your answer there included pregnant people again, because we have been talking about neonates. We've been talking about obesity. We've been talking about adolescence. There's just so much that this book covers. So I'm going to leave you with the most difficult question, Ellen, which is, do you have one takeaway regarding nutrition and pediatrics today?
Pediatric nutrition is hard. We want to make sure that parents know how to feed themselves preconception through adulthood and also to optimally feed their kids. The Yellow Book has so much in it that's practical pearls that we can use, such as what do I do with my picky eater toddler? What do I do with my picky eater tweener teen? How do I feed my kid athlete and make sure that they're getting enough? Okay, my kid's obese. How do I not weight shame or get them feeling bad about themselves while I'm still helping them prevent their fatty liver in the future or their cancer or whatever else that's obesity-related disease? And how do I help my child with obesity believe that they're not defined by their obesity, that they are a whole and well person, and you can use nutrition in a positive way to help improve wellness and health?
Well, this has been a positive experience for us and absolutely nourishing for our minds and souls. Dr. Ellen Rome, thank you for joining us.
Thank you so much for this chance.
To learn more about Pediatric Nutrition 9th edition, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Christy and I just came back from a big road trip, and on half of that we had Julian, because we went back to my home state of Tennessee to pick him up from school for the year. And, you know, there is no better way to learn about your kids' lives than get in the car with them for like 14 hours, and also pick up some really good new playlists. That boy's got great taste in music, and I love just turning Spotify over to him and enjoying.
My Say Ah is about my kids as well, but I guess it starts a little sad. It's that Zelda got an ear infection.
Oh, no.
And it's actually like her third ear infection. She's quite young, so it does stress me out. I'm nervous about it. I was also sick with some cold, but the good thing, the Say Ah, is that I just really took the weekend to relax with her, which I don't often do. And she is 16 months now, and she cuddled right up into my chest and took this amazing nap on me. And it felt incredible. It was a moment I did not want to let go.
I am so glad that you had that moment and are treasuring it. Keep that one with you. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at how to coach families for resilience.
We'll talk to the author of a new book from the AAP, Dr. Gretchen Pianka. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Balinki. Thanks for listening.